Hi, I'm Dr. Melanie Lynch, and I'm the Director of Breast Surgery at Bridgeport in the Yale Health System. And I am so excited to be here tonight to hear the insights and advice from my dynamic and smart colleagues in New Haven. We will have 3 speakers tonight who will discuss innovations in breast cancer care. And our first speaker will be Dr. Elizabeth Berger. She has both a master's degree and a medical degree, and she's an assistant professor of surgery and oncology. Her medical degree comes from Loyola University in Chicago, and where she was also a clinical research scholar, and she completed her fellowship in breast surgical oncology at Memorial Sloan Kettering Cancer Center, where she was selected as a Breast Cancer Alliance Fellow. Her Master of Science comes from Northwestern University. Her research focuses in health outcomes for breast cancer patients, including quality care. And she's going to discuss innovations in breast cancer surgery.
Great. Thank you, Dr. Lynch, for that very kind introduction. I'm excited to be here tonight. Thanks for everyone who's joined. Let me share my screen. And so what I hope to do tonight is just provide some updates in breast cancer surgery. You know, things in breast cancer care changes so frequently. It's really hard, I think, to stay up to date. And so this is a picture. It's a kind of famous social media trend that has been happening recently, is, you know, how it started and how it's going. So Dr. William Holstead used to perform the Holstead mastectomy, or the radical mastectomy, back in the late 1800s, where, you know, the entire breast, as well as the pec major and minor muscle, would be removed. And now Bernie Fisher, who actually recently passed away, who was instrumental in allowing really significant advances in breast cancer surgery for women, said, you know, "In God we trust, all others must have data." And he was, like I said, instrumental in allowing us to really de-escalate our surgical operations for women, and allow them to just really remove the area of tissue of the breast and not compromise any kind of oncologic outcomes for our patients. So we talk a lot about de-escalation of breast cancer care, and really what we're trying to do is provide as good of oncologic outcomes for our patients with less toxicity, less morbidity, and less, you know, disfigurement of the body. And so in the 1970s is when we started to think about, do we really have to do mastectomies for women, or could we just perform lumpectomies and add, for instance, radiation? Dr. Nolton will talk about that a little bit later tonight, and allow for similar outcomes. And that these trials really demonstrated that equivalency of survival and even really recurrence with the 2 operations. Then we started thinking in the late 1990s that maybe women over a certain age, we could de-escalate even radiation therapy for certain kinds of cancers. We also have really significantly de-escalated axillary surgery, so armpit surgery of the lymph nodes. And this has allowed women to spare the morbidity of significant lymphedema in the arm, range of motion problems, sensory changes of the arm. And even into the 2000s and the present day, the Taylor X trial, Dr. Kanowitz will talk a little bit more about, but we're thinking about even de-escalating chemotherapy for some women who have breast cancer in a specific type. And the COMET trial is looking at ductal carcinoma in situ, or we call it pre-cancer or stage 0 cancer, depending upon what you read and where you read it, and maybe not even operating on some patients who have DCIS. So if a patient who has breast cancer needs surgery, what are some of the updates recently, you know, that we are doing actively, you know, at Smilow and across the country? Some of the techniques in localization, so finding the mass in the breast and being able to just do that lumpectomy, have changed. We know that we need to get healthy tissue around the lumpectomy. So what are some of the ideas of what margins mean? Nipple sparing mastectomy. So when a patient does need a mastectomy, as far as what are we doing for nipple sparings? And how are we managing the armpit, the lymph nodes, differently from, you know, years ago? And then I'll get into very briefly, you know, are we operating on women who have stage 4 disease? And, you know, a lot of people have high risk lesions that we're finding now with, you know, improved screening, mammograms and such. And what do we do with those high risk lesions? So just briefly, not all breast cancers are the same. We know 1 in 8 women in this country will develop breast cancer, but there's a wide range of diagnoses. And included in those diagnoses are this principle of receptors. And in a normal cancer, a cancerous breast cell, we often think about what actually feeds the breast cancer to cause it to grow, the cell growth. And so some breast cancers have the estrogen receptor, some have the progesterone receptor, some have this HER2 protein receptor. But again, each breast cancer is an incredibly different kind of breast cancer, and it's really unique to that individual. And so the mainstays of breast cancer care are a lot. It's a very multimodality type of disease. We think about surgery. Oftentimes we think about chemotherapy, we think about radiation, and sometimes we think about endocrine therapy if it's a hormonally driven cancer. But as a surgeon, I think surgery is the most important. Just kidding, of course. But I'm going to talk a little bit about surgical advancements of surgery. So when we think about lumpectomies versus mastectomies, some of the lumpectomy advances we have seen is how do we really localize the lesion or find that lesion, because that little clip that we leave in the breast is only 2 millimeters. And it'd be like finding a needle in a haystack if we as surgeons try to go in and just find it without help. So we used to use these wires. Wires used to be put into the breast, and they still are at times when they're needed or appropriate. And the wires would be put in the same day of surgery. Sometimes the logistics get a little bit challenging. They can cause OR delays at times if the wire localization takes a while. They can get dislodged. They're fairly uncomfortable as far as, you're getting wheeled down the day of surgery to the radiology department, et cetera. And of course, if something were to happen where the case gets canceled, then that wire must come out. The wire would have to be placed again on a dish another day. You can kind of see the challenges sometimes of wire placement that have to happen on the same day of surgery. And now what we've done is really decoupled this idea of localization and surgery. And so what we've allowed to do is we can put these little tags or seeds in next to the clip. Here's a great example of a tag being put in right next to that biopsy clip. And the device gives off a signal. This tag gives off a signal to us in the operating room, and it allows us to find the lesion. We're sometimes able to do smaller lumpectomies because of that. We tend to minimize OR delays because they can be put in days before, for instance, and so we can start right at 7:30 in the morning for operating cases. And oftentimes in various studies, it's shown to improve patient satisfaction with surgery. So I try to explain often to my patients about margins, and I think it's a challenging concept sometimes. So, when we think about the cancer cells in the breast, there's often healthy tissue around the breast, the cancer cells. And what we always want to try to make sure to do is at the edges of this piece of tissue we take out, we want to make sure we have healthy breast tissue. It is incredibly challenging and, a frustration of all surgeons when, we have some cancer at the edges. And oftentimes it's cancer that we can't see, we can't feel. And unfortunately, it ends up being at the edge where it requires a second operation to go back and clean out the margins. There's a lot being done as far as trying to evaluate margins intraoperatively. So at the same time of the operation. And unfortunately, to date, nothing has been demonstrated to be, I think as good as we would like it to be to identify margin status intraoperatively. So, although it's a frustrating conversation to have with patients about how it takes about 4 to 5 days to get these results back, that's unfortunately where we're at right now. But, to be determined in the future if we'll have updates as margin status. So mastectomies, I think the general consensus sometimes is that they're incredibly deforming and that, they're going to leave me with a terrible cosmetic outcome. But what we know now is that we can do a lot of things to, allow women to hopefully feel, as natural as possible, especially with his nipple sparing approach. And we do think a nipple sparing approach is a healthy approach to doing a mastectomy. This is a study looking at, for instance, women with genetic variants and allowing them a very, very good outcome as far as a risk reduction. Actually, one of the authors here is Dr. Greenup, one of our very own here at Yale. And so it's a really nice technique now for women where we're able to save their nipples during a mastectomy procedure. A lot of women think about removing their other breast, so the contralateral or the other side breast, when they have a diagnosis of breast cancer. And it's a conversation I often have with patients. We all probably often have with patients. And I think it's always important to remember that breast cancer does not spread from one breast to the other breast. We do know that when women develop a breast cancer, they have a higher risk of developing a breast cancer in the other breast. But we also know that when we do a contralateral or other-sided mastectomy, it does not improve their survival from their original breast cancer. There are, of course, reasons to pursue, contralateral prophylactic or surgery, in the other breast without breast cancer in it for many reasons, but it's not always right for every single woman. So as far as doing armpit surgery or axillary surgery, we often test these sentinel nodes using two different kinds of dyes. One is blue. You can see here, I tell my patients all the time, the lymph node lights up and it turns blue. Or we use this Geiger counter here, and it really makes a noise in the operating room, and it beeps really loudly, and it tells us what are the sentinel lymph nodes. It's just a fancy word for saying kind of the first lymph nodes that drain the breast. And these are the two mechanisms of how we find those lymph nodes and we remove them. I often hate this word as biopsy because all women we see have really gone through breast biopsies before. And it's not that we stick a needle into the lymph node and test it. We actually remove those lymph nodes to make sure that there's no cancer in them. Like I said, just from the start of the presentation, that we've really tried hard to de-escalate or do less axillary surgery for all the morbidity of it. And this was an incredibly powerful study done in the early 2000s that demonstrated that all women who have some disease in the lymph nodes don't need an axillary lymph node dissection or a removal of all the lymph nodes in the armpit. And it's really allowed a lot of women to spare an axillary lymph node dissection for their breast cancers. This is another trial that I think Dr. Kanowitz will get into further, but this is even now looking at even women who have positive lymph nodes with hormone receptor positive disease. So estrogen and progesterone positive diseases, even women who have positive lymph nodes might not necessarily need chemotherapy all the time. So we're giving chemotherapy a lot more often now before surgery for various reasons, for various kinds of cancers. And what we're realizing as surgeons is that we can still offer that sentinel lymph node biopsy procedure, as I just showed, for women even who have chemotherapy first. And we don't always have to take out all the lymph nodes after chemotherapy. So if we use those two different dyes, the blue dye and the radioactive dye, and we remove at least 3 lymph nodes, what we know is that that's safe for our patients to do. And if those lymph nodes don't have cancer in them, then we don't have to go on to an axillary lymph node dissection. Right now, the standard of care is that if any lymph nodes after chemotherapy still have cancer in them, we would go on and remove all the lymph nodes. But a lot of my patients I talk to, if they're an appropriate candidate for this trial, if there's an ongoing trial asking this question as to whether some patients who have a little bit of cancer still left in the lymph nodes after surgery need an axillary lymph node dissection, or could they just get what we call radiation after surgery? As Dr. Nolton's on the call, she'll talk a lot more about radiation, but why I love breast cancer care is because it's so multimodality and multidisciplinary, and we always are talking to our colleagues in the various specialties to try to take the best care of our patients. So stage 4 disease. So what do I even mean by stage 4 disease? Stage 4 disease is those women who have breast cancer in other organs of their body, for instance, the liver or the lungs or the bones. And there have been various different data to suggest either we should remove the tumor in the breast if a woman has cancer elsewhere in the body, or we shouldn't remove it. And there's varying thoughts on that. But a recent, very well done randomized controlled trial done by a woman, Dr. Khan at Northwestern, really demonstrated that it's going to be most important for women who have stage 4 disease to get on systemic therapy. So some kind of therapy to treat their whole body. And that oftentimes it doesn't, in fact, it really doesn't improve their survival to remove the original tumor. There are, of course, reasons to do surgery on patients who have stage 4 disease. if the if the breast has a bleeding wound, or if there's pain, or something palliative to help local control. But we do think that really helping women who have stage 4 disease to get on some kind of medicine systemically is the best for them up front right now. And then last but not least, there's a lot of questions out there about high risk lesions. And this is a very complicated slide. And I was always told, don't say that out loud because you should change the slide if it's too complicated. But, there are a lot of women are getting diagnosed with various kinds of high risk lesions, such as radial scars or lobular carcinoma in situ, ductal carcinoma in situ versus lobular carcinoma in situ. And what we know about a lot of these high risk lesions are a fair amount increase your risk of developing a breast cancer, but not all have to come out. Some need to come out, and that's a conversation we often have with patients, but not all need to come out. And so it is constantly changing, getting updated. If you ever have questions, we're obviously always able to answer them. And that's all I have for tonight. So let me stop sharing my screen. Thank you for the opportunity to talk about the updates of surgery.
Dr. Berger, 2 quick questions this from the audience. One was, is there ever a time when you would use a wire localization instead of a tag or a seed localization?
Yes, that's a great question. And absolutely. So I think a couple examples, for instance, if we think that after a biopsy, a patient has a very large hematoma, associated blood collection around their cancer, it can be hard to put in that tag and get it in a place where we want it because there's a lot of fluid there. So the wire, for instance, tends to be a little bit more accurate for localizing the lesion if there's a fluid collection around the tumor. And then, a second big reason sometimes is if there's a large area in the breast that we're trying to bracket or get the extent of the lesion, sometimes wires can be easier to understand the extent of the lesion and not putting in 2 tags, just 2 wires. There's a few probably other examples that I'm not maybe thinking of off the top of my head, but I would say those are 2 of the bigger ones.
Yeah, sometimes when it's just too close to the skin or something like that.
Exactly.
And then there's one other question. How is it possible to have a negative sentinel lymph node, but a positive axillary lymph node?
Yeah, the terrible part about cancer is that it likes to spread, and that sometimes, even if lymph nodes are negative, cancer can be in the rest of the body even sometimes. So although we think that the process is the cancer from the breast goes to the sentinel or the first lymph nodes that drain the breast first, cancer doesn't always behave by the rules. So it does sometimes happen that way.
Okay, thank you. That was terrific. So Dr. Kanowitz will be next, and she's an assistant professor of clinical medicine, medical oncology, and she's the medical director of the Smilow Cancer Hospital in North Haven. She received her medical degree from Cornell and completed her fellowship in medical oncology also at Memorial Sloan Kettering. So this is kind of an alumni reunion. And prior to joining Yale, Dr. Kanowitz was the medical director for oncology services at Bristol Hospital Cancer Care Center. And so Dr. Kanowitz is going to talk to us about innovations in medical oncology.
Okay, I'm going to share my screen. Okay, I usually introduce myself as I was born in Brooklyn. I'm the product of the public school education in New York City, and then I went to med school. So thank you for inviting me to talk tonight. It truly is a privilege to help care for patients in this community and to work along with Dr. Berger and Dr. Nolton. I'm a medical oncologist. I prescribe systemic therapies. These are medicines that travel throughout the body and treat cancer cells wherever they are. Why? Because breast cancer is both a local disease confined to the breast, but it's also a systemic disease. How do we know this? The year is 1968. Breast cancer is curable with radical surgery, And we saw those slides from Dr. Berger. Yet not all women remained cured. Dr. Fisher, who was a breast surgeon himself, postulated and then proved that breast cancer is also a systemic disease. And he thought that unless we address microscopic cells that have traveled through the bloodstream, long-term cure will be compromised. No, this is not our oncology clinic during the height of the pandemic. These are the battlefields of World War I. What's war good for? Drug development. Nitrogen gas, or chemical warfare, was noted to be toxic both to the bone marrow and to blood cells. And after the war, it was the first anti-cancer agent used to treat both leukemia and lymphoma, cancers of the bone marrow and the blood. Let's go back to Dr. Fisher's time. We now obviously have more effective and safer chemotherapy drugs, and we have his new theory. A groundbreaking trial was designed to test his hypothesis. All women received curative surgery. Half the group received chemotherapy, half the group didn't. The original study, performed in the 70s, was actually performed in Europe. American surgeons would not let their patients participate because they felt that they could cure breast cancer and chemotherapy wasn't needed. This is the 20-year follow-up of Dr. Fisher's study that proves breast cancer is a systemic disease as well as local. Clearly, the women who got adjuvant or postoperative chemotherapy did better. And the value of participating in clinical trials cannot be overstated. This is your brain on drugs. I mean, your blood on drugs. Germany had a lot of problems in the 1930s. You guessed it. How were they going to mass produce beer? The process of industrial fermentation grew into the fields of biotechnology and genetic engineering. This process was used for fuel, explosives, and medicines like penicillin and insulin. In the early 90s, the same process was used to create a white cell growth factor. And this then allowed for safe, high concentrations of chemotherapy. The panel on the left is a sample of blood. The panel on the right is the same sample after the patient was given white cell growth factor. The purple cells are infection-fighting cells. So now we can safely give high doses, and the thought is, gee, chemotherapy works, maybe more chemotherapy is better. The era of high-dose chemotherapy took place in the early 90s. The goal was to eradicate every last clone of breast cancer and then help the immune system reconstitute itself with this new growth factor. Women were treated on clinical trials, and yet many sought legal channels to get this new promising approach. That is, they sued their insurance company to get this new technology. By the early 2000s, the jury was in, the clinical trial data was reviewed, but the verdict was disappointing. This toxic approach did not improve outcomes. And again, it points out how important it is to participate in clinical trials. That's how we learn how to move the field forward. So maybe there's a better, more sophisticated way. The Human Genome Project was completed in 2003. It took 13 years to complete. Scientists all over the world worked together. Let me just repeat that. They actually worked together, and the entire human genome was identified. Using this same technology, a scientist at Stanford analyzed breast cancer tissue, and he was able to identify distinct DNA patterns but more importantly, he was able to correlate these patterns with outcomes. A risk assessment tool was developed for prognosis, gives us a better idea of what the future looks like, and prediction. What do we predict the best postoperative approach to be? Prognostic and predictive factors are universally used in the postoperative management of breast cancer. And the goal is to stratify women into two groups: those who will benefit from postoperative systemic therapies and those for whom the toxicities outweigh the benefits. Classically, we've used the size of the tumor, the grade, the lymph node involvement to help guide us as to what to do. Now we have Oncotype and 5 or 6 other molecular studies where we look at the DNA of the cancer to predict the behavior of the tumor. So the size of the tumor, women always ask, what's my stage? It's all about the behavior, the biology. Size does not matter. We've heard it before, and you can quote me on that. If the risk is low, we use estrogen blocking tablets only. No chemotherapy is warranted. Dr. Berger had mentioned some of the studies using Oncotype, Taylor X and RX Sponder, so that we use these to guide us. You know, back in the old days, a decade ago, if the tumor was over 1/2 inch, we prescribed chemotherapy. The excitement started in 1979. The gene HER2 was identified. A scientist at Genentech, a new fledgling pharmaceutical company, discovered the gene and the protein that the gene encodes for. Genentech was just bought for $5 billion this past year. So if you were looking to buy it, you lost out. Dr. Dennis Slayman, a medical oncologist, ran into this scientist at Genentech at the Denver airport. They were both returning to California, and they started talking. And ultimately, they both started to work together on the HER2 gene and hypothesized that overexpression or overactivity plays a role in breast cancer growth, and it causes the cancer to grow rapidly and spread. Their goal was to work on a medication that would target or block this growth signal. They ran out of money. What happened? An executive at Genentech came to the rescue when his mom was diagnosed with HER2 positive breast cancer. Harry Connick Jr. played the role of Dr. Dennis Slayman in the Lifetime made-for-TV movie about the development of Herceptin. So the left side is a normal cell, and we can see that the HER2 receptor is on the surface. It sends a message to the brain of the cell, the nucleus. Here's a HER2 positive or overexpressing breast cancer cell, and the messages, there are a lot of messages for the cancer cell to grow and divide being sent to the nucleus. Herceptin, and obviously we found the same slide, Elizabeth. Herceptin blocks that message being sent to the nucleus. It shuts it down. In the 1990s, clinical trials in advanced disease taught us that Herceptin is highly effective against HER2 overexpressing breast cancer, both when given with chemotherapy and also when given alone. And in fact, it's so effective that it was looked at in the postoperative setting. In the early 2000s, there were clinical trials all over the world comparing postoperative chemotherapy with and without Herceptin. This data was presented at a big conference in 2004 in this country. And I was at that meeting. Everything stopped. You couldn't get into the room where the study was presented, and there were monitors all over the pavilion, all over the halls. Everyone was just in awe. Adding Herceptin, trastuzumab, to postoperative chemotherapy reduced the odds of the cancer coming back by 50%. There are now 5 or 6 targeted anti-HER2 drugs, and these drugs and drug combinations are used in a host of clinical settings. These agents have tamed a very aggressive breast cancer and really changed the future for women diagnosed with HER2-positive disease. We're going to move on to another class of systemic therapies, anti-estrogen therapy or endocrine therapy. So estrogen is made in the ovaries and the adrenal gland, and it's guided by communication and feedback between multiple organs, including the brain. Again, to understand where we are now, we're going to go back in time. This story starts in the late 1800s. A scientist removed the ovaries of a lactating rabbit, and lactation or breast milk production stopped. Well, why stop there? The next year, he removed the ovaries of a woman. It was a premenopausal woman with advanced stage or incurable breast cancer, and we saw that the breast cancer regressed. Estrogen was discovered in the 1920s, and we subsequently learned about the relationship of estrogen to breast tissue. But it was clear that depriving breast cancer from estrogen was therapeutic. So over the next several decades, women were subjected to some very barbaric procedures to decrease estrogen. They had their ovaries removed, adrenal glands removed, and even the pituitary gland in the brain. It wasn't until 1967 that tamoxifen was synthesized. It looks like estrogen and thereby blocks true estrogen from stimulating growth of breast cancer cells. It was initially used to treat advanced stage disease, and in 1988, just like the studies using postoperative chemotherapy, we learned that it decreased the odds of the cancer coming back outside of the breast, just like chemotherapy did. And again, we learned this through clinical trials, participation in clinical trials. And tamoxifen is so effective that it was proven in the late 90s that it can be used as a preventive agent for women who are at high risk for the development of breast cancer. There are now multiple generations of anti-estrogen therapies, and anti-estrogen drugs are amongst the most widely prescribed anti-cancer agents in the world. The same way organs communicate to produce hormones like estrogen, there's a lot of communication within cells, both healthy cells and cancer cells. Blocking or interrupting some of these internal messages can overcome resistance or enhance drug effectiveness. So apelacipid or Piqray blocks an altered communication gene and makes anti-estrogen therapy more effective. Everolimus bypasses a resistance mechanism and makes anti-estrogen therapy effective again. Just like in life, there's a time and season for everything, and the same is true for a breast cancer cell. There are times when the cell is more susceptible to the effects of anti-estrogen therapy. And there are drugs that do exactly that, set the stage for the cancer cell being more effective. We have a reenactment below, and this is how I understand it. So this is how I explain it to patients. So, whoops. Okay, so on the left panel, if I'm the cancer cell, Paula is the anti-estrogen drug. She's trying to hurt me, but I can still defend myself. On the right panel, we can add in one of these cell cycle inhibitors that puts the estrogen sensitive cell in a particularly vulnerable state for anti-estrogen therapy. So Amy, who's holding my arms up, makes me vulnerable to Paula, anti-estrogen therapy. And what we're seeing are unprecedented responses when we add cell cycle inhibitors to anti-estrogen therapy, and unprecedented durations of response. Game changer. These drugs are now being looked at in the post-operative setting. Contrary to popular belief, most breast cancer is not inherited. And in fact, only about 10% of women develop breast cancer because they've inherited that vulnerability from a gene like a mutated or altered BRCA gene. BRCA is a repair gene, and when it's mutated, it allows for the development of breast cancer because it no longer repairs the mistake. PARP inhibitors reset this repair process, and this is yet another class of systemic agents that we use for women who have BRCA positive breast cancer. We not only use it in the metastatic disease, we now use it in the post-operative disease, in the post-operative curative setting. Antibody drug conjugates, chemotherapy of the future, I ask. Antibodies like Herceptin not only bind and block the cell surface proteins and block messages, they can really act like FedEx or Amazon and actually deliver packages. So antibody drug conjugates are antibodies where we attach chemotherapy and then we deliver that chemotherapy not throughout the body, but directly to the cancer cell. So TDM1 is Herceptin with a chemotherapy drug attached to it. Sacituzumab is another antibody to a surface protein called TROP2, and it's attached to a very potent chemotherapy drug that we commonly use in colon cancer. So I think what I really want to say is that the treatment today were clinical trials yesterday, and that's how we learn, that's how we move the field forward. So every time we participate in clinical research, we pay forward the benefits that we have for people behind us. And until every woman who's been diagnosed, or man who's been diagnosed with breast cancer is cured, there's still a long way to go.
Needed to unmute myself there, sorry. Two quick questions. The first comes from Dr. Nolton, and she's asking about alpelisib and if it's available off trial, and are you using it?
It is available off trial. So it's used in the metastatic setting, and there has to be a certain alteration in the PIK3 pathway. So we commonly test not only do we do the oncotype testing in the post-operative setting for women whose disease has spread, we also do molecular testing looking for targeted agents. And it's one of the first things that we look for. So we use it along with anti-estrogen agents. And yes, it's an FDA-approved drug.
And the second question is about standard endocrine therapy in combination with Piqray from the start as the first line therapy.
So Piqray has a lot of side effects. It's not a well-tolerated drug. And it's exciting, but I think we're finding right now more exciting the cell cycle inhibitors. So that's palbociclib. We have all these ICLIB names, right? Palbociclib, ribociclib, abemaciclib. They look so exciting that they're all being looked at in the post-operative setting. And it's a little early, but I do think that Piqray will be looked at. I think part of the concern is some of these alterations or mutations only develop after someone's been exposed to anti-estrogen therapy. We don't necessarily see them de novo. So it's something that the cell learns to do to overcome the anti-estrogen effects. Good question.
Good questions, yeah. And Dr. Nolton, our third speaker tonight, excited to hear what she has to say about radiation therapy in breast cancer. Dr. Knowlton's an associate professor in clinical therapeutic radiology and medical director of the Smilow Cancer Hospital Care Center in Hamden. She received her medical degree at SUNY at Stony Brook and a Master of Arts from NYU, and then completed her residency at Hahnemann University, Drexel University. And her specialization in radiation therapy is for breast cancer, lung cancer, and bone metastases. And in 2019, she earned the Smilow Luminary Award for Excellence in Patient Care. So we're excited to hear what you have to say. Thank you.
Thanks, Dr. Lynch, and thanks, everyone. And welcome. I see a lot of patient names in the chat, so thanks, everyone, for coming. And if some of you have seen me talk before at these, I promise you there's some new slides, if you bear with me. All right, I'm going to share my screen now. Okay, and from the beginning. Okay, here we go. Okay, so so this is me, and I have no conflicts of interest to report. So I know that I tried not to be too repetitive from our other panelists, but here's the basics on treatment for breast cancer, which we know often surgery is the mainstay of care. As both Dr. Berger and Dr. Kanowitz discussed, at some points now chemotherapy is becoming before surgery. But I'm the radiation oncologist, so I put the most basic format down here, where surgery can either be breast conserving surgery, where the breast is maintained and only the tumor is removed, or mastectomy, where the entire breast is removed. And there's obviously nodal surgery as well that's involved. And Dr. Berger talked a lot about the sentinel lymph node biopsy and axillary dissection. And plus or minus chemo, as mentioned, the chemo can come before the surgery, and then plus or minus radiation therapy. After breast conserving therapy, usually, yes, we offer radiation therapy, but not always. And after mastectomy, sometimes. And we will get into the details on that and how that's been evolving as part of this theme that you've been hearing a little bit about de-escalation of care with the goal of reducing toxicity while maintaining good outcomes. And then there's hormonal therapy or targeted therapy. This would be the definitive treatment pathway. So what is radiation therapy? So it's a field of medicine that uses ionizing radiation to treat a variety of medical conditions, most often cancer. What radiation really is it's a packet of energy that moves through the air with wavelength and frequency. Wavelength is how high and low does it go, and frequency is how quickly does it go through that wavelength. And that the wavelength and frequency is what gives radiation its properties. So for example, there's radiation from the sun, there's radiation from the microwave, a light in your home is delivering radiation. It could be a blue light, and all of those different ways that if we can see it, if we can't, it's all related to the wavelength and frequency. So ionizing radiation is radiation with enough energy and having those properties from its wavelength and frequency to remove an electron from an atom, causing that atom to become charged. And that's the basis for how it damages the cells. And so the plan when you're treating somebody with radiation is to get enough dose in there to kill whatever cancer cells you're aiming to kill, but not damage the normal cells. And those of you who have had radiation know that, yes, the normal cells do get damaged because that's why you get skin irritation. But the point is to allow the normal cells to repair. They are better at repairing from the damage from ionizing radiation than the cancer cells are. Sorry, I can't, I'm trying to, there we go. Okay, all right, so radiation therapy in breast cancer. All right, so the purpose is to eradicate residual disease within the breast or chest wall or the regional nodes. So that is the reason why following lumpectomy or the breast conserving surgery that radiation is usually offered, because we know from multiple studies that there is risk of having cancer cells left behind, even in the setting of the most amazing lumpectomy ever with nice negative nodes. And we treat higher risk patients following mastectomy, where we think that they are at greater risk to have residual cancer cells left behind. And we see here in this third bullet point, those would be patients with greater than 5 centimeters of tumor within the breast and or involved nodes. And we always want to use evidence-based medicine, so we want to base our treatments on studies, not just on our feelings or what we think the best thing to do. And our treatment is designed to treat the breast or the chest wall, plus or minus the regional lymph nodes, depending upon if that's needed, and to avoid the healthy tissues as much as possible. Even though I said that healthy tissues have the ability to repair, the heart and the lung, they don't need to be irradiated. They don't have cancer cells left behind in them. So we want to avoid the heart and the lung to keep the toxicity down. And as it says at the bottom, a small amount of radiation to the normal organs is safe, but we try to avoid this as much as possible. So if someone were to come to see me in the office, the first step would be, besides meeting a whole bunch of people before me, the registered nurse to do an intake, our social worker to introduce themselves to you, our advanced practice nurse also to kind of lay the groundwork. Then you would meet me and we would do an exam and we would we review your history, make sure that I'm understanding everything that's happened. And we would review why the radiation is needed. And if you've had breast conserving surgery, we would talk about a little bit about why that is and how radiation can improve outcomes. If you had a mastectomy, you had reasons to have the radiation, such as involved nodes or a large tumor within the chest, we would discuss that as well. And we would talk about the treatment course and potential risks and the benefits. And then, if you were to agree to the radiation, we would then schedule the CT simulation. So that's the first step of our radiation, is the planning is to do a CAT scan of the patient in the treatment position so they can design the radiation. When I first went into residency, we were not using CAT scans. Well, they were just kind of becoming the norm. But when I started, we were using fluoro, which is a type of X-ray, and it was much more rudimentary. Even in my somewhat brief career, I've seen such major changes. But the CT scan is used to design the radiation treatment plan. And we do it in the treatment position, because if you think about it, if that's the position we do the scan in, that's the position we design the plan in, then that's the position we need to get you in each day for the treatment. And the treatment position is designed to give us the best access to treat what needs to be treated, the breast, the chest wall, the nodes, and to stay off of the healthy tissues. There's typically for breast cancer treatments, there's no dye given during the CT simulation. So the patient is typically placed on a breast board with or without a mold underneath her. So this is, and you can see in the top right, that's a standard breast board. So every day that a patient were to come in for her treatments, we would make sure that the breastbone was at the same height, and that arm bar that you see at the top that was in the same position. And then this ridge here at the bottom is called the butt stop, so that you don't slide. And everything needs to be in the exact same position when you come in for your treatment as it was for the planning scan. And then we place wires typically around the breast. These are only rudimentary field borders, but they do have importance because they're based on when we were feeling. But we can make lots of adjustments to fine tune them based on the images that we get in the CAT scan. And here, this patient in the bottom right, she has a scar, a wire also over her lumpectomy scar. So we place wires around the breast tissue and on any relevant scars. And you will get tattoos to help us set you up in the perfect position each day. Typically a tattoo on the right lateral chest wall, between the breasts at the lower and at the bottom. And maybe you can see this little dot on my wrist is an old-fashioned tattoo. A lot of my patients in the audience are going to say, what? That's old-fashioned. I have that. Yes, it is now old-fashioned. Because now in the last 18 months we've piloted throughout our Hamden and Greenwich piloted it, and it's been taken on at the other sites where we use tattoos that are only able to be viewed by the UV light. So the patients don't have to have these constant reminders now of these tattoos on their bodies of their previous radiation. But we still have the benefit of the tattoo, which is a mark that won't wash off. And if a patient ever needs additional radiation, it does help us if we ever need to match prior fields. So, excuse me. So after we do that planning scan, then we have to design the plan. So what happens? Well, I have to draw on every slice of the CAT scan, which is done in 2mm slices, sometimes 3, but typically 2. What constitutes the breast tissue, what constitutes the tumor cavity or the lumpectomy bed, the various lymph node regions, the heart and the lung, so that the planning software can recognize it. So that's the first step. Then when I've done that, then I work with the certified medical dosimetrist. A dosimetrist is someone who has a 4-year degree in radiation planning, and certified means nationally certified. And that the certified medical dosimetrist and I work together to come up with a plan using the planning software to give an even dose to whatever needs to be treated, the breast, the chest wall, the nodes or not, meaning that you don't have hot spots with extra radiation or you limit those. And we obviously don't want cold spots where there's too little that's given. And we also want to analyze the dose to the heart and the lung and make sure that they are below what's considered safe thresholds. And let's say are below a safe threshold, but we can do a plan where we're even get further below the safe threshold for the heart and the lung. You always want to do that. There's this principle in radiation oncology called ALERA, as low as reasonably achievable, which means that you always want to have your non-target tissues to have their dose that they receive as low as possible. So when I'm meeting a patient and doing the physical exam, I'm looking for a lot of things. And one of the things I'm thinking about when I have the patient lay back on the table and put her arms up and I'm feeling the breast, my mind is spinning about what's the best position to treat this patient in. Is this patient going to be best treated in the prone position, lying on his or her stomach or their stomach, or supine, lying on the back? We can use different beam angles to come in. We want to angle the beam so that we stay anterior and lateral to the heart. We can use field and field, which is the most modern technique. In fact, another article came out just the other day that I need to read. It's sitting in my in basket, but showing in the old days, you had one beam from the medial and one from the lateral to treat the breast. And you had some very minor ways that you could change how the dose was distributed within that beam. Now, while a patient's being treated, there are leaves that are constantly opening and closing to change the shape of the beam. And that'll help us avoid hot spots and cold spots. And it's been associated with a better cosmetic outcome. So all of our sites are using the field and field technique. Well, one thing that we can do, the dosimetrist and I, is design a custom-made heart block in the head of the machine to make sure, and I'll show you some pictures of that, to make sure that the heart is not in the direct beam. And the use of deep inspiration breath hold, which I have some slides coming up. And I know many of you who are treated with this technique. So here's the supine position, i.e. lying on your back. We see that breastboard here raised up. The arm bar is a little out of the field. There's a butt stop underneath this person's bottom, so but under the sheet that you can't see. And then of course there's the pillow under the knees. So for this patient, each day that she gets treatment, the breastboard is at the same height, the same pillow under the knees, everything is, and then we line up her tattoos. You can see that black X on the corner there, which is helping to draw attention to where her tattoo is for us. The tattoo is just a little dot though. But we line up the tattoos to a laser grid in the treatment room that's calibrated daily by the medical physicist to make sure that the patient's not rotated and the position is spot on. So here's an example of right breast irradiation in the supine position, i.e. lying on the back. And the beam edge you can see coming in here. And there's very little dose spillage that's deep to the beam edge because it's set up in what we call a tangent. It's not like two flashlights coming into that patient. What we do is we angle the beam so that the edge of the beam is what goes into the patient. And that causes what we call a non-divergent posterior border, where very little dose will go behind or deep to those beams. So you can see in this right breast patient, it's super easy to keep the radiation off of the heart, but we would still always use that Alera if we could do something where we still got the breast tissue in the way we liked, but we could spare the heart more. We would always go with that plan. And this patient does have a small liver block, you can see on the right photo, to keep her liver out of the radiation beam. Here's a heart block, which is, one of our tried true ways once we got the CT scan up going, 10 to 15 years ago, to the direct beam. You could see that those are those leaves in the head of the machine that we can shape to follow the edge of the heart. You just have to be careful that when you can't just go crazy in designing the heart block. While we love sparing the heart, we also want to make sure that if we are too generous with the heart block, we won't treat the breast tissue properly. Here's the prone position. This is a patient laying on her stomach in the prone position. Some patients are excellent candidates and some are not. Who would be a poor candidate? Well, a patient that tells me that she's highly uncomfortable lying on her stomach would not be the best candidate. There's certain positions of the tumor. An exceptionally medial tumor is not always the best for prone positioning, for example. And we are not using prone positioning at our institution if the nodes need to be treated. So here's some pictures of some radiation beams in the prone positioning. So you could see for this patient, when you look on the picture on the left, that beam edge is cutting right through and that edge of the heart is right in there. But we see in the prone, we're able to make the beam angle so that the heart stayed behind it. Another benefit of the prone for some patients can be if they have a more pendulous breast with a larger fold underneath. That's an area that can get more skin irritation from the radiation. But if we treat the patient in the prone position, it'll lift the breast up. pH helps a lot. We can see here for this patient on our left where the heart is going into the field edge. And here on our right, with this patient holding her breath, the heart is pulled completely out of the beam. But sometimes you may have had treatment with me and we did the breath hold, but in the end, I ended up treating you with the free breathing, or perhaps with another radiation oncologist. And that's because sometimes it's really not needed. The heart is sometimes nicely out of the field, even without the DIBH. And it does allow a shorter treatment time on the treatment table if you are treating with the free breathing. So that's the kind of the basics about radiation and where we've come, and sort of the most modern techniques to treat the breast and the nodes, try to keeping the doses even as possible and sparing the lung and heart as most as we possibly can. So de-escalation of treatment for breast cancer is interesting in radiation because of course it's related to toxicity, But it's also related to how many treatments you have to come for. And people might say, well, how is that de-escalation of treatment? Well, you think about it, it's less time away from a patient's family, their personal life, less time off from work, and people can have financial toxicity from their cancer treatment. And so if we can help patients finish their treatments and get back to work or get back to doing the things that they enjoy more quickly without compromising outcomes, that sounds like the best plan. So conventional whole breast irradiation was 5 to 6 weeks. So 5 weeks to the whole breast, and then a boost, which is an additional treatments to where the tumor was in 5 to 8 fractions. So people were getting treated for 5 to 6 weeks, even if they had an early stage cancer just following lumpectomy. However, now there's 3 well-done randomized trials, all with 12 years of median follow-up, meaning half of the patients have been followed for longer, that support a shorter course of treatments for patients who receive radiation to the breast alone. And there's a 16 fraction regimen to the breast that would use a 4 fraction boost, or a 15 fraction regimen. That's what we use. So most of our patients now, if the nodes don't need to be treated, are getting treated in 15 or 19 treatments, so 3 or 4 weeks, as opposed to the 5 to 6 weeks. Other trials have found that there's decreased. The large trials found no statistical difference between outcomes and no statistical difference between the side effects. So they were unchanged, although there were some quality of life surveys that went along with it that did find improved quality of life for patients with the shorter course. But some non-randomized and smaller trials have found decreased toxicity, obviously the decreased healthcare costs, and improved patient convenience with the shorter course. So I talked about how at Yale we're doing the 15 fractions to the whole breast, plus or minus the 4 boost patients. And this is typically without additional nodal fields and when the breast is intact. That being said, there are some ongoing studies to say, hey, is this safe to do if a patient's had mastectomy? If you need to treat the patient's nodes, and they're all looking very promising. And in very select cases following mastectomy, I've started using the the shorter course of treatment, the 3 to 4 weeks rather than the 5 to 6, in the setting of treating the nodes or following mastectomy. I talked about a boost, so I just wanted to put this on briefly to show you a boost is typically 4 or 5 extra fractions to where the tumor was. And they are after the whole breast treatment. They're sort of like the bonus. The boost has been shown in the setting of lumpectomy to be helpful for patients of all ages, from under 45 to up to into the 80s, really. However, their update on the boost trials, they were mostly done in the 90s. There was the boost and no boost trial and the Lyon trial. So those patients have a lot of median follow-up now, and they did publish a 20-year update, and they've said that they found that it was most beneficial while it did still benefit patients of all ages, it was most significant to benefit women age 60 and under. I do tend to offer the boost if we're doing the moderate hypofractionation, to offer the boost for most patients under 70. We know 70 is the new 60. But I do talk about it with people that as an option and what are their goals. So now we're getting even shorter, ultra hypofractionation. We have the FAST regimen, which looked at these 5 fraction courses. They actually compared them back to the older 5-week course, the 25 fraction course, which makes sense. That 25 fraction course has decades of data behind it. So they were really comparing it to the gold standard. And these were once a week. So once a week for 5 weeks. And at 10 years, and we like this 10 years in a randomized trial, which is the best type of trial to look for good evidence, there was no significant difference in normal tissue effects. And the outcomes, local regional recurrence, distant recurrence, overall survival, were the same. So the NCCN, which is a National Cancer Consortium network, has updated their recommendations to say that we can use the FAST regimen or consider it at least for people over 50, although I tend to be a little over 60, with early stage breast cancer, meaning they have a DCIS or a smaller tumor and negative nodes who do not require a boost. That is why I try to have my patients that we consider this for be over 60, because remember, the boost was really beneficial for everybody that was under 60, and there's no boost component to this fast regimen. We have not started using the fast forward at Yale. They are using it at some institutions. I know MD Anderson is using it, for example, where those 5 treatments, rather than once a week, are just given Monday through Friday. But we're not quite yet ready for that here. We like to see a little, MD Anderson's an awesome place, believe me, but we would feel more comfortable with a little bit longer data. As you can see on my slide here, there's just 5 years of data rather than the 10 that we have for the fast regimen. And so we'd like to wait a little bit longer on that. And the fast is used for selected patients at Yale, the once a week, not the fast forward yet. But what about omitting the radiation? Maybe some people don't even need the radiation, and that's true. This CALGB 9343 is often quoted. And if patients meet this criteria, they're 70 or greater, their tumor's 2 centimeters or less, they have an estrogen receptor positive cancer, their nodes negative on their surgical procedure, or if they did not have any nodal surgery, on the exam and imaging, and the patient, this is starred because the patient needs to be willing and able to take endocrine therapy, the pill that Dr. Kanowitz discussed, for 5 years. We're really not quite there yet, especially with no adjuvant treatment after lumpectomy for surgery. We do like to see some sort of additional insurance policy, whether it's radiation or the pill. And the other reason is that all patients on this trial did take the pill for 5 years. So at 10 years, the local regional recurrence was super low. With the tamoxifen only, the endocrine pill only, it was 10% local regional recurrence. So 90% of patients basically not experiencing a local regional recurrence, or 98% of patients in the radiation plus tamoxifen arm. So you might say, well, hey, doesn't that 8% have meaning? And it does. It was statistically significant. It does mean if you skip the radiation, you have an 8% greater chance of having the cancer return in the breast. But frankly, a 90% chance of going 10 years without getting the breast cancer back in the breast is pretty good odds. But here's the real reason why it's okay to omit the radiation. It's because there was no difference in the breast cancer specific survival, which was excellent on both arms. No difference in overall survival, which was the same. And many patients in this age group ended up dying of something else. No difference in time to metastasis or the development of distant metastasis. So the 10-year probability of freedom from metastasis was 95% in both arms. So the radiation didn't do anything to improve overall survival for these patients that meet this criteria, to improve overall survival, breast cancer specific survival, or the risk for cancer developing elsewhere. We may see in the next few years that we're opening up this idea of not having the radiation after lumpectomy to more patients. The PRIME 2 trial enrolled women 65 and older, although the number of patients aged 65 and 66 was quite low on the trial. But still the upper 60s now, it's opening for them. And it did allow some larger tumors, up to 3 centimeters. They did have their 10-year update recently at, I believe it was at ASTRO last year or San Antonio Breast Conference, I forget, but they have not published the peer-reviewed paper yet. And I like to wait for the paper rather than just the presentation at the conference. Dr. Berger talked about omitting radiation in ductal carcinoma in situ. So we are at Yale, we have the COMET trial that's open. Our principal investigator is Dr. Gulshan, but it is looking now at withholding even surgery in grade 1 and grade 2 ductal carcinoma in situ. And therefore, if these patients don't have surgery, they're not going to be having radiation. LORD is the same trial open over in Europe, and there's actually 4 international trials, COMET, LORD, and 2 others, whose names are escaping me, but I do know that the principal investigators on all of them meet regularly, and they're going to share their data, which is going to give us a lot of great information. And so we're really looking at, can screen detected low risk DCIS that's found on mammogram, no symptoms with presentation, like no bloody nipple discharge or anything. And if it has to be grade 1 or grade 2, can it be managed successfully with just active surveillance and no surgery? That's the end of my talk, and I'm happy to answer any questions. And I'm sorry that we went over from the 8 o'clock.
Bravo. That was wonderful. And
Thanks.
there are a bunch of questions for you. The first question is about having a lumpectomy back in 2009 with mammocyte radiation. And mammocyte isn't currently used as much. And are the long-term safety of mammocyte still good? Is the data still good? And why isn't mammocyte used anymore?
Okay, all right, that's a great question. Well, so one of the reasons that the mammocyte is perfectly fine treatment, especially for well-chosen patients in the suitable category for what we call partial breast, where we treat just where the tumor was. And that's patients with the lower grade, small or earlier stage cancer, no nodal involvement. And actually, the outcomes as far as recurrence and control of the cancer, they have done well. So why did we stop the mammocyte? Well, it is a bit of an invasive procedure. For those of you who don't know, it has a device, a balloon device that sits within the tumor bed, and you have a lumen that escapes from the body, and it's sewn or attached in, and the patient has that device in her breast for a week while she gets twice daily radiation therapy for Monday through Friday or for 5 days. So it was convenient in that it was done with a week, but it does have that invasive component of having a foreign body in the breast, which can be uncomfortable for some people. But what was really the problem was that the cosmetic outcome was not so hot. Patients, some trials have not shown this, but others have shown that there's more fibrosis in the breast, meaning firm tissue after the treatment. Sometimes that can be uncomfortable for patients. The appearance of the breast was not as good. And now that we are embracing these shorter courses of treatment for patients that don't require having something invasive in the breast, we stopped offering the mammocyte at Yale because of that, because we were able to offer patients shorter course treatments without requiring that. But as far as cancer recurrence, the data is still excellent for well-chosen patients. And I think I did see that you had a ductal carcinoma in situ in the questions. And so I would not, that is not why we stopped it. We did not stop it because of concerns about recurrence.
Okay. And then there's another question about side effects. First, what are the side effects associated with the fast treatment, and how does it compare to regular radiation? And then part B is how can you avoid the side effect of a radiation burn? These significant changes to the soft tissue.
Yes. So it is true that the shorter courses, the 3 to 4 weeks, while it wasn't on those larger trials showing a significant decrease in skin toxicity, smaller trials have shown that there is less toxicity with the shorter course, going from 3 to 4 weeks from the 5 to 6. And subsequently as well, the fast, the once a week for 5 weeks, the data showed no significant difference. However, the patients that we observe, they do tend to have less side effects than acute side effects, i.e. skin reaction, than people that are undergoing the longer course of treatment. Just from when I see them during their weekly skin checks and see them for their follow-up with me, 2 months afterwards. I know we're not supposed to use observational data, but we've seen it. But so I would say that we are seeing less skin toxicity with the shorter courses, and so with the fast having the least amount of skin toxicity. To prevent it, well, we prescribe a steroid cream called mometasone. There's nothing to prevent it. Everybody gets some skin irritation to some degree. what we can do in the planning is limit those hot spots as much as possible, which we talked about a little bit. But then we do prescribe a steroid cream called mometasone. There was a well-done randomized trial looking at patients using mometasone, this steroid cream, once a day, Monday through Friday, and the weekends for one and up to 1 to 2 weeks afterwards. It actually had no negative side effects on the trial that showed reduction in acute skin toxicity. It doesn't mean it made it zero, it was just reduction. But everyone's different, their skin is different. But we also provide a high quality moisture lotion. You don't have to use ours. We just like stuff that doesn't have a lot of scent or isn't heavy on the antioxidants during treatment. And then drinking water and eating protein and allowing yourself to rest and giving it time.
Great, thank you. Any other comments from anybody on the panel? I saw Dr. Berger's answer on active surveillance, which is also a hot topic too.
I don't think it went to Barbara, so I'll send it to the person who asked. Sorry.
All right. Well, thank you so much. And thank you for everyone who joined us tonight for this really great forum. And we're just so excited to have such talented and dedicated physicians in all of our care centers. So thank you again for all of your leadership and have a good night. Thank you.
Thanks, everyone.